Okay, friends, it's 12:15. Thanks so much for attending the call. The ones that who will be looking at the learning management system presentation through their LMS accounts. It is 25th October. Our topic for today is atrial fibrillation, clinical and regulatory review. And then, as usual, we will start with some of our basic slides. There's a disclaimer saying that the CPT belongs to the AMA, and interqual that I use in terms of what's covered for AFib is a product of McKesson. Why this whole thing started many months ago was hospitals were trying to figure out how do we enforce consistency between the intent and the services provided. And they're spending a lot of money in performance measures and improving processes, internal benchmarking. You'd be seeing a lot of consultants with the lean programs, Six Sigma, TQM, data mining. But the whole idea was, the government, payers, CMS felt that there was unnecessary variation causing a lot more money than they had anticipated. And this is one of the beginnings of why we were presenting on clinical topics to the providers. So I always start with these basic slides on, why now? I mean, we've been practicing for many years, but just in the last 5 years, we've been hit by ICD-10. The preparation started 3 years ago. Implementation was last year, and the grace period is now over. So we're going to be seeing a lot more on ICD-10. CMS 1599. This is the 2 midnight rule that's just crossed its third year. And the confusion still remains on what is an inpatient, what is an observation, and we are on CMS calls where that still hasn't been a fully rock solid presentation from their QIOs. EM audits, ACOs, QIO certs, RACs, MACs, ZPICs, OIG, DOJ, HIPAA, high-tech OCR, payers. And then very recently is now the MACRA and the MIPS component. And so, it's not only what sort of documentation it is, but what sort of reporting requirements. And then based on reporting, there'll be audits on whether what you wrote is consistent with what you're asking for payment for. Now, when we look at the spectrum of auditors, just by the color codes, the bottom two are the QIOs and certs. These are our friends. These are for routine compliance. They help us guide, hey, where we're missing something. But if they are not satisfied with us, they refer us to the MACs and MICs and RACs, and that's where, the payment issues come in, penalties come in. And then there's a legal oversight with the DOJ, OIG, and ZPIC. Not to forget the private insurance companies that are sending these notice of improper payments and recoupment for cases that have been at least 3, 4, even 5 years back. So these are some slides from the CMS Medicare and Medicare fraud and abuse prevention. And why I put them is, the perception that started in 2008 was that providers and hospitals are abusing the system and there is some element of fraud. And that's what gave rise to the RACs. And once they started recouping money from 2 states, it was rolled out as a national program. I'm not going to read all the slides and for those who have access to the LMS, they can stop and pause at these slides. But when we talk about fraud and abuse, the primary difference is intention. And so, when the DOJ or OIG think there was an intention to defraud the government, the False Claims Act kicks in, and that's there's very recently we've seen a lot of rise of the QTAM lawsuits where there's a whistleblower who tells what's going on. But Medicare says there's errors, there's waste, there's abuse, there's fraud. Errors could be mistakes, they could be inefficiencies, and what they found is CMS is targeting all causes of improper payments. What they're saying is the most common error or a mistake is an insufficient documentation, and that's how we roll out our topics of the last few months. Is we pick up a disease process and talk about, hey, what should be in that documentation so that we are not penalized on a mistake. So patient quality of care concerns are there, and CMS openly gives numbers out for their beneficiary and family-centered QIOs. for allowing patients to go ahead, put in a comment, put in a complaint if they're not satisfied. There's a bunch of fraud and abuse strategies that CMS has come up with, and integrity contractors, administrative actions, law enforcement actions, but they have these fraud strike force teams, that are located in these hotspot locations, and so they're performing data analysis, they're suspending payments, and then reporting those providers to their respective state medical boards. So when we started the learning solutions, our idea was we want this education to be a single online portal for the physicians, physician advisors, case managers, UR review, admin. It needs to be MACRA and MIPS compliant. So each of our presentation, we talk about these HCCs, CCs, MCCs, because these, we're seeing a lot of level of service denials, medical necessity denials. We were just talking about how the cardiologist and the neurosurgeon procedures, these are high dollar amount denials that the hospitals are facing. And the idea was, when we're giving this education, in order for the hospital to make good avail of it, it needs to have an ROI. So, the amount they're spending on it, we found out it's greater than 300%. There is disease-specific savings based on CMS risk adjustments. They can monitor and track to ensure accountability of this education. And this ROI increases annually with these continuous metric improvements that they have. So in order, it's a win-win-win solution for the hospital, so that their denial rates are down, for the provider because there's a medical legal issue with bad documentation, and definitely it gives good and safe and good quality patient care that's documented. So what we want to start off with, everyone on this call who's already exposed to the LMS knows, going on to aerolib.com, scrolling down, the Aerolib LMS logo is there. Click on it. It'll take you to our portal. Logging in will bring you this front page. There'll be a catalog of disease processes you can look at. So for example, if there is acute kidney injury, if you click on it, it'll take you to the video references, PowerPoint slides. And a lot of this is trackable from whether it's the CEO, the CMO, the CFO, or the Director of Case Management. So let's start with our topic of atrial arrhythmias. As you all know, we start with some definitions, talk about pathophysiology, signs, symptoms, then bring in the ICD-9, 10 components, screening tool, coding tips. And the idea is, once we've talked about a disease process, the provider, the physician, nurse practitioner, physician assistant, not only know the basics of clinical documentation, but they know the back-end business of medicine on why the documentation is important. So atrial fibrillation is it's one of the most common cardiac arrhythmias. It impacts about 2.7 million to 6.1 million American adults, and this number is expected to double by 2050. And hospitalizations with AFib as the primary diagnosis increased by 34% just from 96 to 2001. Now, all my clinical colleagues on the call and the people on the LMS know, this is a classic EKG for atrial fibrillation with rapid ventricular rhythm. This contrasts to this EKG, which is sinus rhythm with premature atrial contractions. And so why I bring these EKGs on this is there is a lot of misinterpretation of EKGs from the computer-aided EKG machines. So it's very important, whether it's the ER physician, the attending physician, the hospitalist, for them to get the diagnosis right. Simply putting in atrial fibrillation for a sinus rhythm and then allowing that to increase the severity of illness of a patient puts the hospital as well as the provider on a very huge high audit risk. When we look at this is the classic sawtooth pattern of atrial flutter. So again, all our physicians on the call and providers on the call are very familiar with these EKGs. I think the idea is to recognize them, to read them, and then to document that you read them and what your interpretation is. So cardiac dysarrhythmias, whether it's it's an irregular heartbeat and tachycardia is greater than 100, that could be an SVT or a ventricular tachycardia. fibrillation is usually exceeds 300, and then flutter is the subnormal rapid spasmodic rhythmic motion. Now, some definitions that are clearly important in the ICD-10 era is differentiating different types of fibrillation. So paroxysmal fibrillation is when the heart returns to a normal rhythm on its own or with an intervention within 7 days of start. So people who have this type of AFib, these are people who come in with palpitations, a few times a year, and their symptoms are unpredictable, syncope, palpitations, just a feeling of pounding in the chest. Now this can convert to permanent AFib, but this is technically billed as a paroxysmal fibrillation. Now persistent atrial fibrillation is when this rhythm lasts for longer than 7 days. Long-standing atrial fibrillation is when this the irregular rhythm lasts longer than 12 months. And then permanent atrial fibrillation, this is when the condition lasts indefinitely. Patient and doctor have decided not to continue any further attempts to restore a normal rhythm. And why these definitions are going to come into play is ICD-10 clearly has different codes for this type. So getting the type of fibrillation is important. Now, what are the sources of what I'm going to be talking? I've taken a lot of resources from the American College of Cardiology. They have released their 2006 clinical performance and quality measures. They've released their guidelines for AFib. All the links to these two documents are at the end of the presentation. So people on the LMS, click on your PowerPoints and then just click on those links. It will take you to these extended reports. But the 2014 AHA-ACC HRS guideline for patients with AFib, they talk about some atrial tachycardias and mechanisms of atrial fibrillation, and they have some really good slide decks for those who want to go in depth into some further clinical information. I think for the purpose of our talk, referring the resources, putting the link on, and then showing you what is on should be sufficient. We'll move on to more towards the regulatory angle. So question is, when does a patient who presents with atrial fibrillation need to be hospitalized? And I apologize, there's a typo on the word hospitalization. But when a patient has an acute MI, an altered mental status, decompensated heart failure, hypotension, uncertain or unstable underlying arrhythmias, intolerable symptoms, when there is a plan for elective cardioversion, when an acute anticoagulation is needed, telemetry monitoring or procedures or EP studies, pacemakers, AICDs need to be placed. Now, remember, this is just for hospitalization. I'm not saying these need to be inpatient. We'll talk about that in the next few slides. But the documentation needed to support the diagnosis, one is an EKG. There are innumerable cases that we have looked at where someone comes in with AFib or a flutter, and these are verbal historical reports from the primary care physician, from the office, and the entire hospitalization does not have an H&P with an EKG on that. Or during that 2-day, 3-day hospitalization, the EKG did not show any evidence, but the medical decision making kept saying AFib. It didn't say resolved. It didn't say back to sinus rhythm. So documenting EKG changes, the presence of an LVH, bundle branch block, old MIs, chest pain, signs and symptoms of congestive heart failure, hypertension, age, and then the risk for myocardial infarction. Now, some of these forms the basis of how the screening criteria, whether it's the MCG or Interqual, but a lot of them have used these support diagnosis tools, and these have been derived from medical textbooks. So they have not created their own evidence-based medicine. They've simply pulled it out from our traditional medical sources, the Harrisons and the Davidsons of internal medicine text. So duration of AFib, flutter is important, history of coronary artery disease, active medical problems, and in a lot of cases, some of the hospitals on the call have problems with follow-up. So if there is an issue of an unreliable follow-up, that needs to be added in this documentation. And why? We'll talk about the CHAD score in the next few slides, and the need for antithrombotic therapy, and then the risk associated with that. But for any H&P that we do, what we have to focus on, and this is a standard slide for all the conditions, Each progress note should talk about, why the patient remains in the hospital. What's the severity of illness, what's the intensity of service. So what is the condition that can only be treated in an acute care facility? And then once you've identified that condition, what's the treatment that's being provided? So patients who have this long-term atrial fibrillation, clearly they've had it for a long time. So what is prompting you to now keep this patient in the hospital, or what has happened to that rhythm? And that goes back to our presentation a few slides back. Is there concomitant CHF? Is there an MI coming? Is there hypertension? Is there hemodynamic instability? But some of the screening tools talk about, if the onset of the rhythm is less than 48 hours, there's hemodynamic stability, there's continuous cardiac monitoring, and medication-wise, you've started beta blockers, calcium channel blockers, or antiarrhythmics, and you've given them more than 2 doses, and the plan is for electrical cardioversion. Some screening tools say, hey, if these conditions are fulfilled, this patient is considered relatively stable. We can observe, do our workup during that hospitalization. However, if there is a need for continuous IV antiarrhythmics or multiple doses, need of a sudden electrical cardioversion, potassium levels are across the roof, there's 6, 7, or even as low as 1.5 or 2, that means that the intensity of service that's being required is far greater. That cannot be done in an outpatient setting. If there's bradycardia, junctional rhythms that are symptomatic, when the monitoring required is continuous, or bolus medications are needed every 1 to 2 hours, or titration of those medications are needed, that generally fits with an inpatient level of service. Now, when I bring observation in inpatient for AFib, this slide is based on the 2 midnight rule, the 1599 rule that came out 3 years back, talking about what makes inpatient based just on the duration of service that's being provided in the facility. So if someone's crossed 1 ER midnight and 1 inpatient midnight, that is appropriate for Part A or inpatient payment. When someone's in the hospital for 1 observation midnight and 1 inpatient midnight, that makes the entire stay as valid for Part A inpatient. 2 inpatient midnights, clearly inpatient. And if these are 2 obs midnights, which is the reason why the whole 2 midnight rule was bought out, is they did not want Medicare beneficiaries being on 3, 4, 5 day observation stays. And that turns it into an inpatient based on medical necessity of the stay. So if someone comes in on a Friday with atrial fibrillation and the goal is cardioversion on Monday, unless this patient is on a continuous cardism drip with a continuous heparin drip on Saturday and Sunday with waxing and waning blood pressures, clearly it seems it's a facility convenience to perform the cardioversion on Monday. So unless they've written some rock solid documentation that the cardiologist is performing to evaluate over the next 48 hours, or elevated troponins, or we need to diurese this patient before we do the cardioversion, it needs to be medical justification for those stays. Now, conduction system specific documentation. So if there's a cardiac arrest, let's identify that cause. If there is paroxysmal tachycardia, so we need a little more specifics on the documentation. Is it re-entry? Is it SVT? What's the underlying cause? Is there illicit drug use, hyperkalemia? For atrial fibrillation and flutter, we have to differentiate what rhythm the patient has, and then what's the underlying cause. Is it a hyperthyroid patient with an uncontrolled free T4, or hypertension, alcohol consumption? Now, atrioventricular and left bundle branch block rhythms, we need to identify the first, second, third, and the reason is, second degree type 2 are the ones that require an urgent intervention. Second degree type 1 Morbitz blocks can be treated medically, and then we need to find out what the underlying cause is. So a lot of the people, on the LMS can pause at this and then read through the other conduction disorders and cardiac arrhythmias that require a little more specific documentation. We just had a case that we won an appeal about 2 weeks ago where someone came in with chest pain and AFib. However, the reason for the continued stay was this extensively prolonged corrected QT interval in the 540 range, attributed to digoxin and potassium disarrangements. And unfortunately, that part of the documentation was not relayed to the insurance medical director, which is why they denied it as an inpatient. However, during the peer-to-peer stage, when we had to go through the EKGs, they were very thorough in asking about the corrected QT, what it was at the time of presentation, what it was a month before, and we finally got this overturned into an inpatient. But it would have been much easier if the hospitalist progress note on day 2 of that hospitalization had made prolonged QT and the reason why we were keeping this patient another day as the top number 1 point in the medical decision making, rather than point 10, with no urgency that was the rhythm that had triggered this hospitalization. So supporting documentation for AFib, the Coumadin treatments, INRs, EKGs, echoes. Some medical directors of insurance companies want to know that if this is a rhythm of concern, was the EP or cardiologist involved or not? So labs, radiology services, and then sometimes a lot of the providers are very savvy in using the V58.61 for long-term use of anticoagulants. But in all our peer-to-peers we've done for atrial fibrillation, one topic has consistently come up on these cases. Is this a cardiac arrhythmia of immediate medical concern? And a lot of times the fact that people with AFib are walking down the street, not everyone needs to be in the hospital. But just like the case of the prolonged QT, I think it was just an insufficient documentation that led to the initial denial. Again, that payment was held for about 60 days before we got the chance to do the peer-to-peer. But that just puts a huge problem on cash flow for the hospital. So a lot of the providers are familiar with the CHADS-2 and the CHADS-2 VAS scores. I think the differentiation is, it gives you the CHADS VAS2 adds some more variables, and then it gives you the prediction of stroke rates. And so when you look at the top right red blocked item, it gives you the CHF, hypertension, age, diabetes, stroke, and the maximum score is 6. The 6 score can give you an 18.2% of an increased stroke risk. The additional in the VASC, CHADS-2 VASC variables was presence of vascular disease, and adding another age variable as well as a male-female variable, making the maximum score of 9%, of 9, with stroke risk going up from 0 to 15.2%. How this is impacted is, this gives you an idea on who requires further intense treatment. So when we talk about AFib, there's the ACCP released antithrombotic therapy guidelines. And again, when you look at these risk factors, these are the same risk factors that you saw in the CHADS VASCU score about female, gender, age, coronary artery disease, thyrotoxicosis, heart failure, hypertension, LVEF of less than 35%. But it gives you an idea on, once you've calculated your risk factors, then you put them in a risk category and then recommended therapy. So not every patient with atrial fibrillation needs to be on Coumadin, and that's something that I know a lot of primary care physicians will admit to the hospital with the thought that this may require heparin and Coumadin. However, when cardiology comes in, they calculate the stroke risk, they calculate what's needed, and it says, well, plain simple aspirin and you can go home. Now, why AFib is important is because it has some comorbid conditions and major comorbid conditions that can affect payments, and that can affect how severe this patient is. So comorbid conditions, these are complicating conditions, and then major ones are that contribute substantially greater severity than a simple CC. These are defined in the Federal Register. So when we talk about cardiovascular and vascular comorbid conditions, there's the EKG findings of trifascicular bundle branch block, the Mobitz type 2 that I was talking, the atrial flutters, history of cardiomyopathy or heart failure, and then malignant or accelerated hypertension. People in the LMS can pause at this time, take a look at these slides. When we talk about major comorbid conditions, you can see things like cerebral edema, coma, endocarditis, acute or acute on chronic systolic or diastolic heart failure. So again, specificity in the documentation. So a lot of people have asked us, we talk about AFib, but how much is it worth? What's it costing us? So these are costs that range from 6 billion to 26 billion a year. Now, 6 billion was attributed directly to atrial fibrillation, and this is from an American Heart Association study in 2015. 6 billion to atrial fibrillation, 9.9 to other cardiovascular expenses, and 10.1 billion to non-cardiovascular expenses associated with the cardiovascular total billing. What we had done is we looked at the arrhythmia reimbursement for a 200-bed hospital. And what we looked at is pacemaker implants, cardiac arrhythmias with MCCs, with CCs, and then without CC, MCC, and then syncope, collapse, and chest pain also. And for 2011, this is data from just CMS patients. They had 412 discharges. Average total payments that they received was $2.1 million. Now, when we looked at this for the entire country, and then again, this is just CMS, all hospitals in 2011, they had 607,000 discharges with a cost of $3.75 billion. Now, this does not include Advantage plans or private payer plans, and usually if we average, this particular hospital had a 1/3 to about 1/4 private payer. So again, this roughly fits with the 6 billion charge that the HA had come out with. Now let's look at some reimbursement issues. So if you have atrial fibrillation as your primary and non-ST elevation MI, your length of stay is about 2.1. There's a reimbursement of about roughly $4,000 to the hospital. But if you go more specifics into the type of atrial fibrillation, with the primary DRG being non-ST elevation MI, and you put in persistent AFib, it turns out to be a DRG of 281. So acute MI with a comorbid condition, your length of stay goes up to 3.1, and your reimbursement is about $5,500. So knowing this definition can impact a $1,500 per beneficiary stay reimbursement to the hospital. This patient may very well have persistent AFib, but if you only wrote atrial fibrillation, they're going to get that $1,500 less. So when we talk about cardiac arrhythmias and conduction disorders, and you have a secondary diagnosis of CHF, it's a DRG of 310, and that will pay the hospital about $5,620. Now, same arrhythmia, but now you have focused on the heart failure, and you've said it's a systolic heart failure. That adds a comorbid condition. Payment goes up to $7,900. Let's say that this patient is in acute heart failure, and that is the cause of the atrial fibrillation with rapid ventricular rhythm. That you've put in IV cardism, IV Lasix, you're anticoagulating. So your documentation now puts in acute and chronic systolic heart failure. Your DRG is 308, and the reimbursement is now up to $10,000. So this is how important the documentation of using the correct semantics of atrial fibrillation, using the appropriate comorbid condition, and using the appropriate major comorbid condition is. Now, if this was a different disease process, AFib, non-ST elevation, MIs, CHF would be another HCCs that would add to the complexity of care that you're giving. So when ICD-9 happened, they had these codes of 427.3.1, 427.3.2 for AFib and flutter. Now, once ICD-10 came in, that's how this definition started happening. So now you have a paroxysmal atrial fibrillation, persistent atrial fibrillation, chronic atrial fibrillation, typical, and then atypical. Now there's always an unspecified one, but again, unspecified for both fib and flutter. My advice to you is try and stay away from unspecified as much as possible. Unfortunately, if you don't add these qualifiers, your coders will use unspecified. So CMS came out with some really good documentation on ICD-10. There's this clinical concepts for cardiology. They talk about location, rhythm name, the equity, and the cause. So, location is atrial, ventricular, or supraventricular dysarrhythmia. The rhythm name is, whether it's a fibrillation, flutter, long QT, sick sinus. The acuity is whether it's acute or chronic, and then the cause is hyperkalemia, hypertension, alcohol. So similar to what we were talking in our previous slides, this is how specific ICD-10 wants us to be. And frankly, this is good documentation. Now, pacemakers are a whole different ball game. There's NCDs for permanent cardiac pacemakers. These were initially put in 1984. 2010, the CERT program identified a number of cases where these pacemaker implanted in patients who only had indications for single chamber pacemakers. Now, CMS on its site has the NCD for cardiac pacemakers, the 20.2, and they have these indications, the limitations of coverage. Very busy slide. I'm not going to read all this, but I'd urge you to pause at this during the LMS presentations or the PowerPoint that you get, and then look at these and then try and educate your hospitalists as well as cardiologists that this is what is approved, and if from a semantic standpoint, this is what will get the pacemaker approved. So future trends. So there's shared decision making between physicians and patients, and this has been I'd say now these are present trends that are now shaping future policies, but rhythm or rate control has been around for years now, and they found really no difference in the long-term mortality or morbidity with rhythm and rate control. Toxicity from amiodarone screening every 6 to 12 months, again, that can be done by the primary cardiologist or the primary care physician. Inappropriate use of anticoagulation in patients with extreme low risk of stroke. So if your CHADS2 VASC score is 0, that patient does not need to be started on anticoagulation, at least not with Coumadin. Prevention of reoccurrence, and then dose adjustments for the new oral anticoagulants. There's been some talk about how EHR and computer-aided documentation is coming into the ER, where it can improve the sensitivity of diagnosing some conditions like bowel obstructions, renal colic, appendicitis. In this particular presentation, much more sensitive EKG machines are coming, which can give you a far greater diagnosis. I say that with a caveat. A machine will only read what it's programmed to do, and that's where the ER physicians, the hospitalists, the cardiologists come in. I'd say don't trust your machines blankly. Don't start treatment based on the machine readings. Look at the rhythm, look at the patient, do an H&P, and then figure out if that rhythm is there's limitations of artificial intelligence of that machine. Now, when we talk about MACRA coming in, just yesterday we were talking about another disease process on how MACRA is coming in, but this is the rule came in effect last week. There's 2,200 pages on it. What we did was we pulled out, page 677 talks about activities related to population management subcategory, and they talk about atrial fibrillation, how patient education, care coordination, appropriate dosing decisions, especially the novel oral anticoagulants, because it does pertain to primary care physicians monitoring those. When we move down to page 2084, there is the measure title in internal medicine and family practice. They have atrial fibrillation and atrial flutter. So percentage of patients age 18 years and older whose assessment of the specified thromboembolic risk factors indicate one or more high risk factors. So they do expect patients with AFib, the primary care physician, the cardiologist, the NPs, PAs, doing those risk assessments for stroke and then determining if they need treatment or not. Atrial fibrillation in CHF has a huge readmission issue going on, and so you can pause at this slide, but a lot of the readmissions, they're categorized into clinically necessary versus not clinically necessary, and this is the entire bucket where they will club those admissions into two and not pay for that particular encounter. So it's important to stop at this slide for a few seconds. If the not clinically necessary was it an inappropriate readmission in terms of incorrect assessment, inadequate post-discharge care, or preventable complication, and then non-clinical readmissions. This is where the economic and psychosocial issues come in. Is hey, I didn't have a place to stay, or I couldn't refill my medication. These are links to what we had talked about. and you can go on to the LMS. Like I said, go on to what topic you want. The atrial fibrillation one will be put up by the end of the day today, and so you can encourage your physicians to come in.